Here we are on a nice, sunny November 2nd, 2013 with Dr. Jerry Clermont, a general surgeon who has practiced most of his career in Worcester. Good afternoon.
Hi, how are you, Dale?
I'm fine, thanks. Why don't you tell us a little bit about how you made your decision to become a physician?
It took a while. Back when I was in teenage years, I was still helping my father in the grocery store back then, and we were talking about it, especially in going to college and what I wanted to do, etc. At that point, there was a lot of discussion based on some of the things I was reading in Life magazine, which was a big deal back then, Life magazine. And Albert Schweitzer had gotten the Nobel Peace Prize. Actually, he had 4 PhDs, but he got it for medicine because he was going out as a missionary in the Congo. And after that kind of whet my appetite a little bit. But then Tom Dooley got a lot of coverage from Life magazine, and he was doing his in Laos. And back then, we didn't have the communication we had like we have now, and nobody knew about Laos. This was a big deal. And he was describing a lot of the cases that he was performing, and that really piqued my interest. And so back when I went to Holy Cross to college, I took the pre-med course. Not really into medicine yet, had nothing to do with medicine. Nobody had gone to college, even in my family. I really knew nothing about medicine except for what I read in the lay press. But sounded good. I got good grades, so I figured why not try it. And as time went on, I became very much interested in the service, the art of medicine. And so I think this is what really piqued my interest the most. Why I went into surgery, it was directly, no question, a result of a surgeon I had met at the Peter Ben Brigham Hospital back then. Now it's Brigham and Women's. This was Dr. Francis Moore, very well-known surgeon. He had written a book. It had just come out when I was a medical student on metabolic care of the surgical patient, and I read it cover to cover. I thought that he was a brilliant man, and I wanted to emulate him, basically. And so that's how I got into medicine and surgery. And I hope that answers the question. It's nothing
Sure.
spectacular, but it was a gradual transition.
Excellent. And what years did you go to medical school?
I have to think back now because it's been a while. I graduated from Holy Cross in '61, medical school in '65. I went to Harvard Med.
Mm-hmm. And so you were in medical school when Vietnam was winding up and getting to be a major thing.
It was getting there. It hadn't really drawn the United States in at that point. It wasn't truly until about halfway through my residency where President Johnson got us into the war. Of course, all you got back then was just what you read in the papers, and it all sounded reasonable at the time. But in retrospect, one wonders about some of the reasons why we entered into that war.
Mm-hmm. And you then did your residency, and where did you do your residency?
I did it at Strong Memorial, University of Rochester, New York.
Mm-hmm. In general surgery?
General, and we did vascular surgery. Our chief of surgery was Charles Robb, who at the time was an internationally known vascular surgeon, probably known best for having, at least by his description, done the first carotid. Of course, Dr. DeBakey always said he did the first of every vascular procedure, but who was to argue? Certainly Charles Robb wrote the first paper on it,
Mm-hmm.
and so he got credit for it.
Mm-hmm.
But he drew a lot of vascular patients into to strong memorial, and I'd say probably a good 30% of my cases were vascular cases.
Wow. And what was life like as a resident then?
Totally different from what it is now. There were no restrictions on hours. Um, we weren't as well known as beating the residents to death like they were at some of the institutions. We were actually allowed to have a family. Obviously, there were some institutions that didn't even allow that. But I was putting in an average of 100 hours a week.
Mm-hmm.
I was on every other night as an intern.
Okay. And you were married and had a family at that point?
We did, yeah. We had 2 kids.
Uh-huh. Excellent.
Exactly. Yeah, we
Wow.
got married young. Obviously, still married. 51 years. So it's been a good cooperative marriage.
Mm-hmm. And so you were on every other night. You were working about 100 hours a week. And your residency lasted for how many years at that point?
It was a 6-year program. We had 1 year in the middle where we did research for a year.
Mm-hmm.
But it was a 6-year program.
And then after residency, where did you go?
And United States Navy. Back then we had a deferral process. You either got deferred for 2 years and then had to go in after your first year of residency, or you got a full deferment. It was, they said, strictly pulling your name out of a hat. I had gotten a full deferment, so I went in at the end.
And then at the Navy, where did they station you?
Well, I was initially supposed to go to Vietnam. I would have gone on to the hospital ship, the Navy hospital ship in the Gulf of Tonkin. Not exactly a difficult or dangerous, I should say, position, but it would have taken me away from the family too for a couple of years. But all of a sudden, at the last minute, they transferred me to Alaska. The gentleman who was supposed to go to run this base at Alaska, the hospital on the base, wanted to go full-time Navy, and he wanted to get the credit, and he chose to go to Vietnam. So I did a family trip to Adak, Alaska.
Wow. And what sorts of cases did you see? What role did you play?
Well, I was the head of the hospital. Now, we weren't a huge base. We had about roughly 3,200 people there, including civilians who worked there as engineers, etc. In other words, whatever the Navy didn't have, they hired civilian contractors to do it. And they had their own little section of the island where they were residing. They had 3 separate posts on Adak. I was at the naval facility. They also had a naval facility there, and they also had a communication station there. And I took care of all of those and controlled all of the medevacs, because we took care of the entire North Pacific. And so we would have to go on medevacs pretty frequently, ships that had a problem.
So did what you learned during your residency prepare you for that?
Well, what I did my senior year, or chief residency year, I made it a point to go to all of the different specialties, knowing that I was going to Adak, Alaska, and tried to get a flavor for all of the specialties where I had not rotated. We rotated on quite a few. I could handle the ear, nose, and throat, the orthopedics, the urology. I could handle those. But I did a little bit of extra GYN. I did a little bit of obstetrics. I hadn't delivered a baby in quite a few years at that point. Wanted to at least get my hands wet. Did a little bit of neurosurgery, a little bit of the things that normally you don't see in your residency program.
Wow. And how long were you in Alaska?
2 years.
Wow. And then from there?
From there, I had an option. I could have gone to, I wanted actually to go to San Diego. It's a big naval base in San Diego. where you could do some teaching and all. But there was no position available, so I left the Navy and had my discharge paper signed by Richard Nixon. I made sure I saved that. It's a memo, I guess, you know. But at any rate, while I was there, I had taken my boards. I flew into Anchorage to take my written boards, and then took my oral boards in San Francisco. So passed the boards first time on both of those. I guess that probably goes to show that you don't have to study crazily for your boards. There was nothing out there. There was no library to study in. And so I just practiced and enjoyed myself while I was there, and had no problem passing the boards. And while I was in San Francisco, I had met with Dr. Brownie Wheeler, who was the new chair of the Department of Surgery at UMass, which had just opened. A year later, the medical school opened, and a year after that, they began to have a program, a residency program. So there was a hiatus there. I had an office, even had my name on the door, but there was nothing for me basically to do. And so Dr. Wheeler made arrangements with the Fallon Clinic to have me work at the Fallon temporarily at first to at least fill that interval. I thoroughly enjoyed working at the Fallon. It took me about 6 months before I actually had privileges to do surgery. Back then, group practices were not the norm, you might say, and there was a lot of animosity in the city about having this group practice. They were excellent physicians, and but it wasn't the quality of care that made any difference as far as the politics of medicine goes. So it just took 6 months for me to get my credentials to do surgery. So I did primary care. I had done a lot of primary care anyway. We had a program so that we got exposure to a lot of primary care, and so you know, I had no problem doing that for 6 months, and in fact built up a fair number of people in my on my list, and they were very disappointed when I got my surgical privileges and no longer could see them. So that's how we got started.
Wow. And in the 1970s, what kinds of cases would you do? What sort of problems would you address?
Well, first of all, with the vascular background, I got a lot of vascular consults. They didn't have a board in vascular surgery back then, so I did a lot of the vascular stuff. In fact, I think I was the first one to put in a vena cava filter, for example, here at St. Vincent's, using the jugular root, that type of thing. And so I got a lot of the vascular consults. I got consults actually in quite a few of the surgical specialties. I did not get privileges to do chest, so I would refer those over to either Jerry Carroll or someone. But nevertheless, I did a fair amount of general surgery, but the bulk of general surgery at first was done by Dr. McCready and Dr. Rutschneider. They did the bulk of the general surgery.
Excellent. And what sorts of hospital stays would there be? How was life in the hospital in those days?
Well, everybody basically got admitted. There were a small number of outpatient surgeries, but there were no day surgery units back then. There were no independent standing day surgery programs. If you wanted to discharge somebody on the same day, you could do it, but they certainly were welcome to be admitted, and it was very easy to do so. Typical gallbladder would stay about 5 days, for example. That was basically the norm at that point. Hernias got admitted overnight and got discharged the next day, sometimes stayed 2-3 days. So it was a different type of practice back then. Everything was done open. There was no laparoscopic procedure done at that point. And everything was paid for by insurance with our group. We had we called it a closed panel group, basically. And so they were patients of the group, and so I took care of those patients.
Mm-hmm. So the model then, are we talking about the Fallon Community Health Plan?
Not yet. That came
Okay.
into being. I'd say probably right around 73, 74, 75.
Mm-hmm.
Right around 75 is when they came in. When I first came to the clinic, I shared an office with John Myers.
Mm-hmm.
Like I said, I did primary care. And so he took me under his wing, and we had some discussions about HMOs. It was a new concept to me, but it was an interesting concept, and Dr. Myers was very astute. He wanted it started, and he got it started. And so, with the help of a few key people at the clinic, they made it work. Now, I know very well how it got started. It got started because we would take on people who had very little risk. They were younger people. They didn't have a huge risk. We didn't have a senior plan initially. And so, obviously, the doctors in the community were aware of this. And, again, that didn't help our relationship with the rest of the community. But at any rate, it did work. And there were no co-pays, incidentally,
Mm-hmm.
Initially. That all came about in time. And then about, I guess, roughly around 78, 79, that's when the concept of a senior plan came in.
Mm-hmm.
And that's just about the time when, with the seniors now, we knew that the seniors were going to utilize a lot more of the facility. They were going to cost a little more. That's when we started charging copays.
Mm-hmm.
The first copay was $2. It was a $2 copay, and the people, of course, complained about it. And the people at the desk even complained about it. Sometimes they wouldn't even collect it.
Mm-hmm.
So there were some rough times initially with the copays, even though it was only $2. You can imagine that now. $25 is a copay for specialists.
Sure. So you joined the Fallon Clinic. It still probably wasn't nearly as big as it is today. How many physicians were there when you joined in the early 70s?
I was about number 21.
Yeah, and it subsequently has grown to, at this point, over 200 physicians.
That's correct. Yeah,
Yeah.
and we didn't contract with any outside physicians initially either.
Mm-hmm.
This was just a closed panel HMO now
Mm-hmm.
that we had.
Mm-hmm. Excellent. And again, probably into the 80s, from the 70s to the 80s, how did surgery change? How did your practice change?
Well, I did more and more general surgery. And as the older physicians, Dr. McCready, Dr. Manning, all of the older physicians were doing less now. And I began to do more and more general surgery. We then hired a vascular surgeon who wanted to get his vascular board, so people would feed him the vascular surgery to get his numbers up so he would qualify for boards. So I was doing a little less, quite a bit less vascular as I did general now. Also, there were more specialists around. And so the specialty services now were doing most of their own type of work, which meant less that I was doing, because I was doing everything at first. I wouldn't hesitate to do a hand case. I wouldn't hesitate to do some of the things that no longer was I, quotes, allowed to do, which didn't make me work any less. It was made up with all of the other stuff that I was doing. So I was averaging at the peak around 650 cases a year.
Wow. Wow. And then what other evolution have you experienced during your career with regard to just the technology and the results and the procedures in general surgery?
Well, interesting, disease doesn't change. An appendix is an appendix. A bad gallbladder is a bad gallbladder. It doesn't change. Technology, however, has changed. Now, you go to the emergency room, they've already got a CAT scan done on somebody. That's where most of the abuses of CAT scans occur. But nevertheless, yeah, technology has made a huge difference, not only in the approach to the patient, but also the cost of health care itself. A huge difference. And so I don't think it's for the better myself. And I try to teach that to the medical students, that they need to use their hands, their eyes, their stethoscopes. They need to make a diagnosis before you go and get these new technological advances done. Mm-hmm. And believe it or not, for a surgeon who did a lot of surgery during my time, I tend to be a little anti-surgery now at this point. I've seen a lot of complications that never would have arisen had surgery not been performed.
Sure. And so during your training and your career, imaging has changed a great deal. Did you have much in the way of ultrasound being done in the 60s and 70s?
In the 60s, there wasn't. We did our own arteriograms, incidentally. Mm-hmm. Of course, now that's almost a specialty within radiology itself. Mm-hmm. So a lot of the invasive procedures initially were done by general surgeons. And rapidly it was taken over by specialists in their fields. Mm-hmm. And so, yeah, all we had back then initially was an ultrasound. We didn't have a CAT scan. Mm-hmm. That very quickly came on. I'm not sure exactly when it came on, probably in the 80s.
Mid-70s, 80s is when the technology was being developed, yeah.
And as soon as it came about, every hospital had to have it.
Sure.
And then after that, every emergency room had to have it. Sure. And the same was true with MRIs in the 90s when that came out.
Yeah.
Everybody had to have it. And I guess fiscally, it was a necessity to have it, but has it made a difference in how diseases are treated? Mm-hmm. Has it made a difference? And the answer is no. Hmm. Death rates are the same. Hmm. Everything is the same. It's not the surgeries especially, and that's where I have to come from, is from the surgeries, because that's what I did all my life. I don't think it's made that much of a difference, except in longevity. It's kept people alive longer. Mm-hmm. Mammograms have kept women alive a little bit longer. Mm-hmm. We pick up the breast cancers earlier. We pick up things earlier with using the technology. I guess maybe the jury's out on whether it's worth mm-hmm. A couple of extra years mm-hmm. that you get based on the cost. The United States spends more than every other country in healthcare. Mm-hmm. Way more than every other country. And Massachusetts spends more than every other state. Mm-hmm. Worcester County spends more than any other county. This right. is the most expensive area for healthcare.
Right.
No question. And is it worth it? I don't know. I think the jury's still out.
There's plenty of employment in it.
A lot of employment. And that is interesting, that the biggest right. employer in every community that has a hospital is the hospital.
Right, right. And then with regard to your charitable activities, you've done a tremendous amount along those lines.
Yes, that's a result, I think, of the Albert Schweitzer, Tom Dooley concept that I had when I first went into medicine. Never left. I always wanted to do that. And that all began after I got here. I did some work when I was out in Alaska. Went on a Navy tug, did some work in the islands out there, and that kind of whet my appetite a little bit for it. And when I got here, I started up a group We called it CHANGE, C-H-A-N-G-E, Children's Healthcare and Nutritional Goals Through Education. I made that initially so I could actually go out and recruit some money and recruit some people so that they could do some foreign trips. And back then you could do foreign trips. I could actually bring kids back here to the United States and get some work done at either Children's or UMass, and it wouldn't cost them anything. Back then the hospitals had enough in their pot so that they could do this type of thing. Well, that worked for about 10 years, and then it began to deteriorate considerably. Hospitals, you had to beg them to take the people. If it was an interesting case, they would take it. Otherwise, routine things they wouldn't take. They wouldn't take oncology patients. They were very expensive to treat. And so they had a lot of these made-up criteria, you might say, on who they would take and who they wouldn't. And then eventually they wouldn't take anybody. So I got out of the foreign stuff back in '96. That was my last trip. I did a trip to Nicaragua then, and that was my very last trip. I used to do 2 trips a year, 2 weeks each time, and went mostly to Spanish-speaking countries because I spoke Spanish. It was a good time. It was a good time. My wife and I had 36 kids that we brought here as foster kids. Stayed with us, and they got their care, usually at UMass, or I think 1 or 2 at St. Vincent. They were tough. St. V's was always tough getting somebody in. But nevertheless, they got their care done, and then we sent them back home. So in '96, I started with Change, working at first with down at the Epworth Methodist Church with Paul Hart. He started the first free medical program here in the town. And 2 years later, I branched out and approached St. Anne's here in Shrewsbury because it was, number 1, more convenient for me, number 2, centrally located so we could draw a lot of people, and number 3, I knew that St. Anne's was known to help the community. They had a food bank, they had a thrift shop, so I said, that's for me. So I approached the pastor, took him 2 days. He contacted everybody on his board, and we had the place. So they renovated the stage, made some examining rooms for us, and in September of 1996, we opened St. Anne's. And it's still thriving. We have increased our numbers. I'd say probably when Romney Care went in, we had a sudden jump in the numbers. And then after that, it's been kind of a steady peak of around 80 people in an evening.
Wow. And this is 80 people in how many hours?
2.5 hours.
Yes.
Well, we have a lot of help at St. Anne's. So we have a lot of students. We have medical students from UMass. We have nursing students. We have several nursing schools here in town. In fact, they're very competitive because a lot of their nurses have to put in some time in the community, and so they're begging to come. And they come with an instructor, and so we keep a schedule for them as well. And then Mass College of Pharmacy opened, and they have not only opened and have students come, but they've expanded. They have other schools. They got a PA school, a nursing school. Now they have a school of optometry. They're expanding all the time and looking for places to send people. So I welcome them. I said, gee, you know, that it's a good thing. I would love to have a new program every year added to St. Anne's. My only concern is that I'm going to do this for about till I'm 75. I'm 73 and a half now. So, you know, that's not a long time, year and a half. I don't know who's going to take it over.
Wow. So what sorts of, it's interesting that you say that the year they signed into law a universal access program for the state so that more people would have health insurance, your numbers went up. And yet we think of your clinic as being a place for people with no insurance and no money.
Right. And it is a place for people with no insurance. Not necessarily no money, but definitely no insurance. Um, I know the figures. The state loves to say that 98% of the people are covered by insurance. But what they fail to say is that 98% of eligible people have insurance. The non-eligible are the immigrants, number one. That's probably the largest number that I see. A lot of the immigrants, as you know, come in and stay. They overstay their visas. They now become the illegal immigrants now. And not only are they in, but they invite their families in. And a lot of them will stay in the apartment buildings along Route 9, where it's relatively inexpensive to stay, and not unusual to have 9, 10 people, intergenerational, living in an apartment like that. And they can't get medical care. They are residents. They can get emergency care, but they can't get routine care. So they come to St. Anne's. We've been around long enough. They know they can come. They know they're welcome. We don't ask any whether they're legal or not. We ask about insurance, but we still treat them. The only thing I can't give them if they have insurance, I can't give them the immunizations. That's all, because we get our immunizations from the state, and the state has very strict guidelines that you have to follow. So that's about the only thing we can't give them.
And what sort of problems do you see at these clinics?
We see very routine, urgent problems like they see in any urgent care. I even do minor surgeries, INDs, and things like that at the clinics. I do that before the clinic opens usually, so I don't take up a room to do a surgical procedure. But otherwise, we see seasonally. Right now, we're seeing a lot of allergies. Wintertime, we'll see a lot of bronchitis, and we'll see a lot of infectious diseases. In the springtime, allergies again. Summertime, we see a lot of bites and injuries and a variety of things in the summer. Actually, the peak time for me is just before school starts, because all of the school nurses send the kids who can't get to see a pediatrician and get their physicals for school. They send them to St. Anne's. And so we do their physicals. We have a good working relationship with all of the school nurses. I have a lot of respect for the school nurses who do a great job here. But we told them initially, send the kids in, but let us know how many you're sending in. We can get overwhelmed with the kids. And we give them immunizations as well. So that's been a very satisfying program for Shrewsbury. But we see kids from other school systems too.
They just know that it's a good place to come.
Exactly.
Excellent. So during your career, what are some of the advances that you feel made the biggest difference for your practice?
No question, laparoscopic work. It became very quickly a specialty. And at the stage I was in when it came out, I was probably 53, 54, something like that. I really didn't want to go and take a fellowship in this at that age. And we still had to do routine general stuff, routine vascular, and I was still taking trauma call. And so I was busy enough. I didn't need to go and take a special fellowship. So that kind of bypassed me a little. All I was doing laparoscopically was appendectomies, simple cholecystectomies, routine stuff. I never did any bowel resections. I never did any of the other newer laparoscopic techniques.
And looking back also, what other things would you say were in medicine 30 years ago that you kind of wish were preserved now? What?
Well, the biggest thing, I think, is just the personal relationship between the doctor and the patient. No question, And I warned people about that years and years before, that the insurance companies were going to interpose themselves between the physician and his patient or her patient. And now, when they advertise, you're advertising for Fallon Community Health Plan, Tufts Plan, Blue Cross Blue Shield. It's not the doctor. It's we have all these doctors, but this plan is the best. They second guess the doctors. They impose restrictions on them. They have to see so many patients in such a period of time. They keep tabs on them. They'll tell them every month, you saw X number of patients, you worked for X number of hours, you're below the average. That's not the way to practice medicine. That I think is baloney. And they're getting darn good salaries. All the administrators are making darn good money. Some of them making more than the doctors are. And now we're seeing more physician extenders. They can get PAs now because they have more PA schools now. And they're hiring them. And they're actually acting as a primary care physician. And not that they're bad, but they can probably take care of maybe 80% of the things that come in, but they don't have the knowledge base to diagnose anything that is absolutely serious. They are very slow also in ordering things. They don't want to look bad when their profile comes up before the administrator. So I think with the use of physician extenders and with the increased numbers of administrators, I think that physicians now are being pushed to the side considerably.
You, I think, are unique in that you've had so much experience with organizations during your career. Right out of your residency, you were running a hospital. You had to build teams. You had to administrate. And you've done that as well with your volunteer work and the like. And, has that colored your perspective on things? It gives you a perspective that perhaps is a little different from the person who only sees their practice.
Right. It's like what I tell the medical students this now. Whether it's going to stick with them or not, I don't know. But I tell them, listen, you come to the clinic, you're here for 2 hours. This isn't the clinic. This is basically you're seeing a couple of patients. You're getting an experience, which is a good experience, and that's why we have it. But there's a lot more to running a clinic than just coming in and seeing a couple of patients. Where do you think all this stuff is coming from? Why is it organized this way? Why are people coming from in each of these areas to take care of the people? And they start thinking about these things. This is what a good administrator, I assume, does, is that they have to have their finger on the pulse to make sure that they see the big picture, that everything is going to run smoothly. We don't take any surveys or anything. We don't run it, say, are you satisfied, 9 out of 10 and all. Pretty much everybody who comes to the clinic is treated well, treated with respect. And that's what I hear from the patients. No 9 out of 10s and 10 out of 10s. Every now and then we'll get somebody who's disappointed. Drug seekers are very disappointed. But right up front we have our sign up, no controlled substances, period. Usually when a new clinic opens up, they try. But that's it. They try once. That's, you're probably right. I probably have a little more administrative work in my background than many of the physicians do.
Wow. This is excellent. Any other subjects that you want to cover today, or any other remarks you'd like to make?
Well, there's a lot of different things in my life that I've seen. We've adopted several children, and actually for a period of time did a lot of adoptive work. In fact, UMass had an adoption center there for a while, which unfortunately had to close, but we did some work with that for a good length of time. But I thoroughly enjoy medicine, and right now I know that I would not be happy doing anything else. And I tell the students too the same thing. If you're not happy, maybe you're not in the right specialty, or maybe you're not in the right profession. If you don't have fun, then it isn't worth it. You want to go to bed happy. You're going to be tired, so you're going to go to bed. You're going to go to sleep, unless you're the type that worries all night long about something for the next day. But you got to be able to put that out of your mind. And I think that the biggest help for me was the fact that I was putting in during my residency, getting brainwashed with 100 hours. You could just remotely just do things just at the drop of a hat. You knew what needed to be done. You did it. There was no putting it off. You did it. Was that good or bad? I suppose maybe during the time there were mistakes made. There's mistakes made now. And you read articles, there's mistakes all the time. That hasn't gone down very much in the years, despite all of these quality issues. So you got to have fun.
Okay. That's a great note to end with. And thank you very much for doing this interview for us.